Ay, perdón. Welcome, everybody. I hope you're okay. We are really happy to have you here again. This is our second webinar, and this time the topic is appendicitis. Before we can start with Dr. Violeta, I would like to recall you that this webinar, the first objective is that you can improve your English. You can be listening, write it down, and everything you want to do so you can improve your English, and also you can learn a lot about this topic. Also, remember that we are going to have 7 webinars. So if you want to have your certificate of attendance, you must be registered in 4 webinars. In a few moments, the form is going to be in the chat. So you can register your attendance, sorry, and it's going to be, remember, it's going to be open only the first 15 minutes of this webinar. So for begin, I would like to introduce to Dr. Violeta Cervantes. Doctor, we're really happy to have you here. I know we're going to learn a lot with you. So if you like, you can start anytime you want to.
Okay, thank you. Good evening, everybody. Thank you for being here. Okay, I hope you like this webinar. And let me just say that I've been practicing and attending surgeon for 5 years, 5.5 years now. And since then, I found that that a lot of things have changed in the study of appendicitis. So this was very good to me because I learned a lot too. There are a lot of things I didn't know, and I hope I can digest it for you and that you will be able to understand it better. So I'd like to start by sharing my screen. How do I do that?
It's open so you can share it.
I'm sorry, I tried to use it a little before, but I haven't really gotten the hang of Zoom.
While the doctor is ready, I would like to recall you that if you have any question, we can wait until the presentation is over and you can write it down and I can tell it to the doctor, or you can open your microphone and do it easily. Remember that no one is going to judge you. The system here is that you can practice your English. So please don't be shy. You can do it. And if you feel stressed or something, we can help you also to do the question.
Okay, I've got the presentation ready, but I don't know how to share it.
If you go down on the screen, there is a green button and it says share screen. Down in the screen, there's a share screen. You can push it and then it's gonna open another window, and in the window is gonna be the different size of your screen.
How is that?
Yeah, you're sharing, but we are not watching your presentation. We are watching your something.
Okay, now?
Yeah, we can see, I think,
Can
a
you
video.
see the presentation?
We can see a video, I think so. I think it's a endoscopy.
Oh, yeah.
Okay.
Mhm. Is the title on?
Yeah, it's the title of appendicitis.
Okay, then we're good.
Okay, you're ready.
So, appendectomy is the most frequent emergent abdominal operation worldwide, and its highest incidence is in the second and third decades of life. Now, my name is Violeta Cervantes, as you already know. I'm a general surgeon, and it is a very common disease. So first of all, I'd like you all to think of someone you know who's had an appendectomy. A relative, a friend, yourselves, maybe you yourself have had an appendectomy. So it's a very common disease, especially in children, and there are many causes for it, and we'll be looking at them shortly. So what do you remember about that person? Or have you heard of someone who said, well, I began feeling pain and then I threw up, and then they took me to the doctor, and I don't know, a lot of the things that happen are easier to remember if you have information about it previously. So if you've already seen a patient or been a patient with appendicitis, it's easier for you to grasp, to connect with the knowledge. So worldwide, the incidence of appendicitis is 8.6% in men and 6.7% in women. And it's very common in children. Here, we're going to look at what the appendix is, what it does, why it gets inflamed, and how to diagnose it, which I think is the most important thing, and what the treatment is. So mummies have been found to have right lower quadrant adhesions in the abdomen, which proves that appendicitis has been with us the whole time since we've been humans. So it's not a new disease. Here we can see a drawing from Leonardo da Vinci, and he had already identified the existence of the appendix in the colon, in the cecum. I don't know if you know who this is. This was Harry Houdini. He was a famous illusionist, and he famously died from a ruptured appendix in 1926. Before 1886, before Reginald Fitz called it appendicitis, it was also known as typhlitis or perityphlitis. But Reginald Fitz established the term appendicitis, and that's the one that got stuck. Here we can see a drawing of the first successful appendectomy. It was in 1735, performed by Claudius Ammian, and this was in a 10-year-old boy. He had swallowed a pin, and the pin got stuck in the appendix, perforated it, but the appendix was also inside a hernial sac. So that is usually called an Ammian hernia, when the appendix is inside the scrotal sac. But as from 1982, Dr. Kurt Sem, a gynecologist, performed the first laparoscopic appendectomy, which is now the standard treatment. Not in our environment, not in public institutions such as mine, but worldwide, it's supposed to be the standard treatment, laparoscopic appendectomy. So here we have some pictures of the anatomy and the embryology of the appendix. The appendix is attached to the cecum. It begins where the 3 teniae of the right colon converge, and that's where the base of the appendix is. It is also called vermiform process because vermiform means that it's shaped like a worm. So you can see that it really is shaped like a worm, and it's close to the ileocecal bulb. We can see the appendicular artery, which is a branch from the ileocolic artery. And this is a question I've heard asked a lot of times. And why does appendicitis have a migrating pain? I don't know if you have heard about this or have been asked about this, but it has to do with the embryological origins of the appendix. On the right-hand side, we can see a picture where it says 6 weeks gestation, 8 weeks gestation, 9 weeks gestation, and that's the midgut. And the appendix develops around the 8th week of gestation, but its base is in the middle of the abdomen. And you know the rotation, the external rotation of the intestines, and then when they go back in, at 12 weeks gestation, the cecum gets lodged in the right lower quadrant, and that is usually its most common place. So all of the nervous fibers come from the midgut. We'll talk about that a little bit further. And I don't know if I'd like to interact a little with you. I'd like to know if what have you heard about the function of the appendix? Because it used to be thought that the appendix was only a vestigial organ, which means that in the course of evolution, the appendix had a different function, but now it's just a remnant. And it was thought that way not so long ago, a few years ago when I was a student in medicine, it was said that the appendix had no function. But now it has been found that the appendix has a very important role in the preservation and development of gut-associated lymphoid tissue, which helps regulate the immune response by the gut. And it also maintains the intestinal flora with beneficial microbes. So it's not just an empty sac. It's got a lot of lymphoid. It's got an immunological role, and it has even been recently researched that it might have a neuromodulatory response. But it's still under research, so it's not certain, but it probably has to do with neurotransmitters, which is still a little too complicated. So the appendix is a true diverticulum. Again, I'd like to ask you, I don't know really how to do that, but I wonder if you know what a true diverticulum is, because the appendix is a true diverticulum and the colonic diverticuli are false diverticulum. So that's the difference between a true and a false diverticulum is that it's got all of the layers of the intestine. You can see the mucus, you can see the submucus, You can see the muscular and the serous layer, and a false diverticulum does not have all of the layers. So that's the difference. And well, the appendix is innervated by the superior mesenteric plexus and the vagus nerves. Now, the pathophysiology of appendicitis, and it's really interesting, and let's go over it. First of all, the lumen of the appendix is really small. It's just a tiny duct. It's a blind sac. It's got only one way in and out, and it can get obstructed by fecalis, otherwise called appendiculis. It can be obstructed by food, by seeds, by lymphoid tissue. That's especially common in children because they have a lot more lymphoid response. So the lymphoid tissue gets hypertrophied, and that obstructs the lumen of the appendix. So what happens when something gets obstructed in the body? What happens when a kidney stone blocks the ureter? It gets infected because the bacteria can proliferate there. So it happens the same. It's the same thing with the gallbladder. Sometimes a gallbladder stone can get lodged and obstructs the passage of fluids, and it gets infected because of the bacterial overgrowth. So this happens here in the appendix too. And because the appendix is a part of the intestine, it keeps secreting mucus. And so the mucus and the bacteria begin to distend the appendix. It begins to get painful at 50 to 65 millimeters of mercury. And by the time it reaches 85 millimeters, the venous flow and the lymphatic flow get impaired. They get a lot of thrombus, and the wall gets really, really congested. So the intraluminal pressure keeps getting bigger and bigger, and the distension, which causes a lot of congestion because the arterial flow keeps coming in the appendix, but the venous flow cannot take that blood out. So it gets really congested. And this congestion leads to obstruct the arterial flow. So now we're going to have ischemia, and the mucus gets ulcerated. Because the mucus of the intestine gets ulcerated, the bacteria can crawl out from the appendix into the outside, and they can go through the wall of the appendix, which is called bacterial translocation. And that aids to the inflammation. So once we have enough ischemia, the wall gets perforated, and all of the contents come out. Sometimes patients have a lot of pain, and when the appendix gets perforated, they feel relief because the distension no longer is causing them the pain. But there's a lot of infection. There are theories that perforated appendicitis and non-perforated appendicitis are different diseases. It is now being studied as to why sometimes, even though the appendix is is inflamed, it will not perforate. And sometimes it will perforate really soon. So it is believed that maybe they are different diseases. They have a different etiology. But you know, that's not yet proved, but it's a part of the research in appendicitis, the current research. Does anybody have any questions so far?
I think there is no question right now, so if you have any, you can write it down also. But no, I think they're good.
Okay, let's move on. Okay, I hope this was clear. This is an important part of understanding appendicitis. And here we can relate the stuff that's going on inside of the body, inside of the abdomen, and the things that are going on with the symptoms of the patient. You know, at first, when the appendix gets obstructed and begins to get dilated, there's a referred visceral pain. And that's why the pain is felt in the mid-abdomen, around the navel, in the epigasters. So that's the beginning of the distension, the visceral radiated pain. But then as the distension and the inflammation progresses, that pain is overcome by the somatic pain of the appendix. So that's why the pain migrates from one place to another. And that is a classical hallmark of appendicitis, although it is not 100% of the cases. Some cases happen with sudden pain in the right lower quadrant, and they never had migration, and they do have appendicitis. So, but it's really helpful when the patient says that their pain moved from one place to another. Also, what is the difference between a migrating pain and a radiating pain? You know, the pain radiates from one place to another, but it keeps hurting in the place where it originated. I don't know if I'm being clear about this. For example, in a gallbladder colic, you can have pain in the below the rib, below the right rib, and that pain radiates toward the back. But the pain under the rib never goes away. They have both pains. And the pain that migrates is just one pain that goes from one place to another. I hope that is clear for you. That is also an important thing to ask the patients. And the more we ask them about it, the more we'll have experience, and we won't get confused, and we'll ask the patients in a more practical way. In this case, E. coli and Enterococcus and Bacteroides fragilis are the most common bacteria found, especially in perforated appendicitis. So they are gram-negative. Okay, now I believe this is the most important part, the diagnosis. How do we diagnose a patient? The first step is to interrogate the patient and get all of the information that we can. Then we go to the physical examination and the laboratory findings, and then the imaging. There are in age groups, there is a difference in diagnosis, different age groups. For example, in children, especially small children, it's more difficult. If the kid is under 4 years old, it is a lot more difficult to diagnose because they cannot give us enough information by speaking, and we need a lot more support from the laboratory findings and the imaging in the imaging methods. We'll be looking at them in detail. First of all, the interrogation. You know, how do we begin interrogating our patients? First of all, we are going to introduce ourselves, and we're going to ask about all of their pathologies, whether they have chronic diseases, whether they take daily medications. I find that sometimes you ask a patient if they have a chronic illness, and they say, no, I don't. And then you ask them, do you take any pills, any medication? Oh yeah, I take aspirin because of my heart, and then I have to take painkillers because of my knees, and that gives me heartburn, so I take omeprazole. And they don't consider that a chronic disease. So it's important to get as much information from the patients as we can. And it's also important to ask them about surgical interventions. And then we go on to asking about the reason they are in the ER, the reason they seek out medical assistance. And I usually advise to do it in this order, because let me give you an example of what happens when you do it the other way around. I'd like you all to look at this image. You know, there's a desk and there are a lot of things, a lot of people working there. So I want you to notice, I want you to take notice of everything that is blue. You know, I need you to look at everything that's blue and take it into account. Remember this, because I'm going to ask you. Remember, look at everything that's blue in the picture. Okay, now please close your eyes. No one is watching you. Close your eyes, and now try to recall everything that's red. Can you do that? Can you remember everything that's red in the picture? I think you probably won't. So because when you were looking at the picture, you were focusing on the blue stuff and never noticed what was red. So this is similar to what might happen in a patient when you begin asking them about their pain, whether they've thrown up, whether they've had fever, and because you're thinking of appendicitis. And at the end, you're going to check their belly and you see a scar and ask them what the scar is. And they say, oh, I had an appendectomy. So everything you just ask the patient is meaningless, because you had a different differential diagnosis in mind. So that's why I advise you to ask the patients first as much information about themselves as you can. There's an exception here. There is something called stump appendicitis. This is a special consideration. Stump appendicitis is what happens when the patients had an appendectomy, but more than 5 millimeters of appendix are left in the patient. So someone who's had an appendectomy and begins with appendicitis pain can have appendicitis again if they had a stump left over 5 millimeters of appendix. So as surgeons, we are obligated to remove all of the appendix, to remove all of it. Sometimes it's really hard to find the base of the appendix, but it is necessary because if we don't remove it all, the patient can develop appendicitis again, and the diagnosis will be a lot more difficult because you'll rule out appendicitis. You know, the patient's already had an appendectomy. So that's just one exception, but ideally, a patient who's had an appendectomy will not have appendicitis again. The incidence of stump appendicitis is 1 in every 50,000 appendectomies. So it's really rare. It's really not common, but it does exist. This picture is about the different positions the appendix can take place. We can see the tinea coli. There are 3 in the cecum, and they converge, and that's the place where the appendix springs out. So that is usually constant. The base is usually constant in the right lower quadrant or the McBurney point. But the tip of the appendix can be all over the place. And depending on where the tip is, the patient will have different symptoms or will have different signs when you explore them. I mean, they can all have nausea, vomiting, fever. Sometimes they can have a little diarrhea. Sometimes they can have pain when they pee. They can have signs of urinary infection, but the pain does not always manifest itself when you research the patient. For example, if the patient has a retrocecal appendix, which is the most common location, when they move the psoas, they will have pain because the psoas muscle is behind the cecum, and usually the appendix is in between those two. But if the appendix is in a pelvic position, the patient will probably not have a lot of pain when performing the psoas sign, but they will have a lot of pain when performing a rectal or a vaginal exploration. So those are a few differences that can take place in the patient, in the size of the patient, depending on the tip. Okay, here we have an abdomen, and I thought I'd explain to you all of the signs of the appendix, where they are, but I think that's boring. I'd much rather show you. I recorded a video I'd like to show you now. Just a moment. I'm sorry, I had it ready. Oh.
Good afternoon, doctor.
Hello, Mr. Bradbury. I'm Dr. Cervantes, and I'm the attending surgeon. I will be checking your case today.
Okay, thank you.
So, how old are you?
I'm 29.
Okay. Do you have any chronic illnesses?
No, no,
Have you had surgeries?
no,
Okay. Are you allergic to anything, to any medication or
no,
food?
neither.
Have you had transfusions? Blood
No.
transfusions? Okay. Well, tell me about the pain.
Well, it started here in the center by my belly button, and then it moved over to my right side. Right now it hurts over here in my right side.
And did it stop hurting by your belly button?
Yes.
It doesn't hurt anymore
No.
then. Okay. Since when? When did the pain start?
This morning.
Okay. Have you had any food? Are you hungry?
Well, I had breakfast, but I wasn't very hungry, and I threw up afterwards.
Okay. Are you hungry right now?
No.
Fever? Have you had a fever?
I think I have, but I haven't checked my temperature.
Any other symptoms? Diarrhea, or does it burn when you pee?
It doesn't burn when I pee, but I had when I went to the bathroom, my stool was loose. But it wasn't diarrhea, but it was a bit loose. So.
Okay. Well, I'm going to check your belly. Could you please lay down for me, please? Please lay down comfortably and place your hands where you feel them more comfortable. And please, could you lower your pants just a little bit more? Thank you, that's enough. So first, I will be touching your belly lightly, and from the place where it doesn't hurt to the place where it hurts the most. So, does this hurt?
No.
Does this?
No.
This hurt?
A little bit. Oh, yeah,
That
it hurts
hurts?
there.
Okay. That's called hyperesthesia. Now, does this hurt?
No.
Here?
No.
Here?
A little bit.
Here?
Yeah.
Here? Where did it hurt the most?
Over here.
Okay. I'm going to press a little bit more, okay? Try not to push. Try to relax your stomach. Does it hurt here?
No, it hurts over here.
So if I press here, it hurts on the other side?
Yes.
Okay. Well, does it hurt here?
No.
Here?
No.
Does it hurt here? It hurts the most, right?
All right.
Okay, so here is a McBurney point. It's a line between the front iliac prominence to the navel. So you kind of draw a line, and on the first third, here is a McBurney point, and that's the place where it's supposed to hurt the most in appendicitis. So if you press here, that's a positive on the McBurney point, but when you let go, it's called a Bloomberg sign. You know, I press and then release, and the pain is greater when you release your hand because of peritonitis. So another sign is the pelvic flexure. It's called the iliopsoas. I'm going to bend your leg, and I'm going to rotate it. And that moves the psoas muscle, and it's pain. Now, could you please cough a little for me? Does it hurt when you cough?
Yes.
Okay, and how about when you walk?
Only when it's bumpy, it hurts.
Okay, so that usually is because of the irritation of the peritoneum.
Okay, I'm sorry, the audio wasn't very good. I didn't realize that. But you can see that the patient, I think you've all heard of it. There's this beach sign, signo de la playa, where the patient is all relaxed and they don't look like they are hurting. And you see them from afar. You can see them from the other side of the room of the ER, and the patient is like really relaxed and they move freely and they walk freely. I take advantage of having to transfer them from one place to another to see how they walk. Patients who had an acute abdomen, who have peritonitis, try to move slowly because the movement makes them hurt more. So the patients try to move as little as they can, and they don't jump into the gurney. They kind of lay down very carefully, not to have pain in the abdomen. And in children, you can ask them to step on their toes, stand up on their toes, and then go down really hard or jump. So they will not do it because they know that it will hurt, or when they do it, they will cry out because they will have pain. So that's an easy way to check if they have peritonitis. But usually adults don't jump when you tell them to, so it's better used in children. Yes, so the McBurney point is 1/3 of the distance between the anterior iliac prominence to the umbilical region. Yes, here, about here. Brobsing sign is when you press on the left side, you press on the left lower quadrant, but it doesn't hurt there. It hurts at the McBurney point. So that's a Brobsing sign. And Dunphus sign is when you cough or you jump and there's pain. Obturator sign is when you move your leg, well, the patient's leg. You move the patient's leg and there's pain. They extend their leg sideways. And the iliopsoas sign is a pelvic flexure, like the one I showed in the video. These are some of the most important. There are a lot. There are a lot of signs of appendicitis, but these are the most common. And I advise you to practice them and use the ones you're more comfortable with and the ones you know how to assess, because sometimes you don't know how to explore a sign, so it's better to use the ones you already know and use them well. Bloomberg sign is when you take away your hands, you press and then take away your hand and it hurts. Now, for the diagnosis, once we have a complete clinical history and a proper physical exploration, we can use the Jerusalem guidelines. These were created in July 2015 at the World Congress of the World Society of Emergency Surgery. And they got together with the intention of creating guidelines which didn't exist for acute appendicitis. And they were last updated in last year, 2019. So it would be really interesting for you to have a look at them later, so that you know what the current recommendations are. There are many scores used to diagnose appendicitis. Maybe you've heard of some of these, maybe some you haven't. For example, this is the Albedo Score and the modified Albedo. I think it's too much to review them one by one and all of their criteria because they are similar. Most have right lower quadrant, tenderness or pain. They have leukocytes over 10,000. They have neutrophilia. They have anorexia, nausea, vomiting, most of them. They just change a little in account to how to score the point. Here are the Albedo. We also have the Ripasa. They are developed mostly for Asian populations. This is a pediatric appendicitis score. You can see that the criteria are similar: fever, migration, anorexia, nausea, vomiting. And you can see that when you get less than 4 points, you get a low risk, 4 to 6, a medium risk, and 7 to 10, a high risk of having appendicitis. The Jerusalem guidelines suggest that to diagnose pediatric patients, the Albedo and pediatric appendicitis score are the best to use. You know, they are for pediatric patients. And there is also a pediatric appendicitis risk calculator, which you can find at MedCalc. But you know, the guidelines recommend to use this one in pediatric patients, the PAS, the pediatric appendicitis score. There is also an adult appendicitis score. This one is the newest. And you can see that they take into account whether the patient is a man or a woman, and what the proportion of neutrophils is. They take into account also the C-reactive protein, which is something new, which is something different from the other guidelines. There is also the AIR score, the appendicitis inflammatory score. So this also takes into account the C-reactive protein. In adult patients, these two can be used. You can use either one of these. And it is recommended that in pregnant women, an imaging study is also used, not just the scores. Now we move on to the imaging studies, because you know all of the scores, you can find them, you can have them on your phone. It's good to know what they are, but you really can't just look them up. You don't have to know them by heart. This is a simple X-ray, an abdominal X-ray. And right now, X-rays are not very useful in the diagnosis of appendicitis. They used to be because there were no MRI scans or there CT scans before, but now it's not very useful to have an X-ray because they show an appendiculis in 7 to 15% of cases, which is not a very sensitive measure. We can see here an appendiculis. I don't know if you will. I placed an arrow there to help you find it. Here we can see the appendiculis, and we can also see that the cecum is filled with feces because of the inflammation, but really it's not used anymore. There is a little controversy here, but the first line of imaging in diagnosis appendicitis is the ultrasound. It is not as sensitive as a CT scan, but it does not have ionizing radiation. So it's really useful in children and in pregnant women. on the left side, we can see the appendix in a coronal view. You can see that it's shaped like a target. It's shaped like a target, like a shooting target, Diana in Spanish. And you can see the terminal ileum, the psoas down, but on the left side, you can see the wall of the appendix that's inflamed. And on the right side, we can see the appendix on a longitudinal shot. And I placed an actual appendix to show you the resemblance of what we see in the ultrasound with what we can see, with what we have in reality inside of the abdomen. In the abdominal ultrasounds, we can have aperistaltic, non-compressible, dilated appendix. But the most important thing is to locate it. Once you locate it, you can look at all of those things. But you know, they say in radiopedia.org, because I'm not a radiologist, they say that that's the most challenging thing about using ultrasound to diagnose appendicitis. And now we can see these are some CT scans. Here on the left side, you can see there was a little blue point that appeared. That's where the appendiculus is. Can you see that? Here it is. And here is the appendix. That's the shape of the appendix and the red oval. And on the right side, can you find the appendiculus and the appendix? I'm going to give you a moment to look at it. We can see the liver, we can see the intestines, we can see the heart. We can see the bladder in the center down. And here is the appendiculus, and here is the appendix. There is something, if you notice here, the fat is black, you know, it's got a black color. But around the appendix, it's a little whiter, and that is called fat stranding, because the fat around the appendix gets inflamed and it looks a little bit whiter in the CT scan. This is an MRI in a pregnant patient with acute appendicitis. And you know, MRIs are the opposite from CTs. You know, the white stuff looks dark and the dark stuff looks white. So in this case, we can see the appendix and it's dark, so it means it's a little thicker. And you can see the uterus. I can't make out where the baby is, but you know, this is not a full picture. Yes? Okay. Now, what is considered a complicated appendicitis? A complicated appendicitis is when you find an inflamed appendix with gangrene, perforation, or an abscess around the appendix. And you know, I came up across this really interesting article that's called Pathophysiology of Acute Appendicitis. And I really recommend you to read it because it explains really well the pathophysiology of appendicitis, but it also mentions that a perforated appendix and a non-perforated appendix might actually be different pathologies, have different etiologies, like I mentioned at the beginning. And it also mentions the new term called neuroimmune appendicitis, which has to do with enteric neurotransmitters. So it's really interesting. I really advise you to read it. And I'll tell you about the complicated appendicitis, because of the treatment. I'm going to skip ahead a little because I already mentioned this. The treatment for appendicitis has traditionally, since over a century, has been appendectomy. But now, maybe you've heard about this. There are some studies, there is research about treating appendicitis only with antibiotic therapy, not by surgery. So a few days ago, the New England Journal of Medicine published a randomized trial, which you can see there, the name is there, a randomized trial comparing antibiotics with appendectomy for appendicitis. And one of the most important differences when deciding to treat a patient with antibiotic only or with appendectomy was whether it was complicated or not. So that is why I mentioned what are the characteristics for a complicated appendicitis. So it is considered that if there is not a sign of complication, it could be treated by antibiotics only. It does not have gangrene, it's not perforated, it doesn't have an abscess, so it might be treated with antibiotics only. But you know, this is a debate, because appendectomy has a cure rate of 99%. Like I said, if you perform an appendectomy, you are going to cure the appendicitis and the patient will never have it again unless they have a stump. But it has a little more risks, such as wound infections or an intra-abdominal abscess and ileus. And the antibiotic has a cure rate of 70 to 90%, but they have a recurrency rate of 15 to 30%. So they might save the patient from an appendectomy at one presentation, but then the patient can have appendicitis again. So it has a lot more recurrency. Let's go back here. The differential diagnosis. What do we think about when a patient has abdominal pain? You know, as I said, it depends on the patient. It depends whether the patient is a man or a woman. Is it a child? Is it a pregnant woman? Is it an elderly person? And so in young women, we have to rule out an ectopic pregnancy. That can also manifest as abdominal pain in the right lower quadrant. You can have labor. You know, the patient might be in labor and that is why their abdomen is hurting and not because they have appendicitis, or the other way around. The patient might have abdominal pain and you can think that they've gone into labor and it turns out they have appendicitis. So in pregnant women, that is why imaging methods are advised. Gynecological illnesses should also be ruled out in young women. They can have an ovarian cyst torsion, they can have a tube inflammation, they can have a pelvic inflammatory disease. So you have to rule out the diagnosis depending on the characteristics of the patient. They can have kidney stone, they can have even basal pneumonia can mimic a pain on the right side. So you have to really notice, you have to really get all of the information from the patients. And, you know, in children, the most important differential diagnoses are intussusception, gastroenteritis, malrotation, mesenteric adenitis, torsion of testicular torsion, an ovarian torsion, and even pregnancy. They can also have ectopic pregnancy if it's a girl who's already started menstruation. There is even difference whether it's a baby, whether the patient is 2 to 5 years or 6 to 11 years. You have to rule out when the baby is really small, a colic, constipation, a urinary tract infection, a volvulus, incarcerated hernia, Hirschsprung's disease. And then as the patients get older, you have to differentiate the possible diagnosis. Children who are really young are really hard to diagnose, and they can get complicated really easily. So the treatment, the surgical treatment of appendectomy has an accepted negative rate of less than 10% in men and less than 20% in women. What does this mean? It means that sometimes you are doubtful, you don't know for sure whether the patient does or does not have appendicitis, and you operate on them, and maybe the appendix is fine, but you know your accepted negative rate of appendectomy is less than 20%. So if out of 10 you operate on a negative appendicitis once, it's not a big deal. There is a saying in the residence. There are a lot of sayings, but there's a saying, si le duele y rebota, se ganó su rajadota. I think most people who've been in hospitals have heard sayings such as this, but I don't think it's justified. I mean, you can't just operate on a patient if you don't have a reasonable doubt. If you have a reasonable doubt, if you don't have a diagnosis and you can still perform further explorations, further investigation, but you just operate on them, I don't think that's a good idea, because it is not advised anymore. I had a patient once who had abdominal pain, and he was hospitalized as diabetes. He was 19 years old, and he was diagnosed as diabetes, type 1 diabetes. And the patient was in really a lot of pain when in the hospital, and his blood glucose was almost normal, but he still had a lot of pain. And it turns out he had an appendectomy when he was 9 years old. And he was really distended. He had an acute abdomen, so I operated on him. And it turns out that the cecum had a little adhesion to the abdominal wall. It was an adhesion about 3 centimeters long, and he had an internal hernia. The intestine had rotated around it and it got obstructed. So by the time I got him into the OR, he already had an strangulated intestine that could not get recuperated. I had to perform a resection of the intestine, and all because he had one small adhesion from an appendectomy when he was young. So there really is a risk. If the patient does not need it, it's better not to perform it. Maybe you've heard of this. This person was Leonid Rogozov, and this doctor, can you see what he's doing? What do you think he's doing? He was a Russian doctor who was in an Antarctic expedition in 1961. And he was the only doctor on the team, and he developed appendicitis. And there was no one else there to operate on him. He was the only doctor. And so he tried to take antibiotics. He tried to treat himself with antibiotics, but he did not get better. He kept getting worse and worse. And then he realized that his only choice was to perform an appendectomy. And he trained his team. He trained his, I think it was a driver and a nurse. And he told them what to do. Whether he passed out, he told them how to perform CPR, and they kind of helped him a little, but it says that mostly they just stared at him as he was performing the appendectomy. He had to do it, obviously, with local anesthesia. So he couldn't see. He placed a mirror in front of him so that maybe he could look at what he was doing inside of his abdomen. But he said it was really hard. He kept passing out, and he kept having to stop to rest because it was really difficult to operate on himself. But he succeeded. He got better. We can see him here talking to his friend, and he got better. He was recognized as a national hero. And because the Soviet regime said they had some of the strongest soldiers and the strongest and most valuable people in their ranks. So I think this is a story worth knowing. I think it's very brave. He had no other choice, and he did it, and he survived. Right here, we can see a view from a laparoscopic appendectomy, and marked here are all of the different anatomical points. In the center up, we can see the appendix. We can see the tinea. That's the cecum. That's where it's the base of the appendix comes from, and the terminal ileum. When you see it like this, it does not resemble the picture I showed you earlier of the anatomy, but you need a lot of practice to identify the structures. So maybe next time you're in an OR and you're looking at the laparoscopic surgery, it will be easier for you to identify all of these structures. and it's different from what the book says. There are some last considerations. In older patients, appendicitis might be harder to diagnose because they might have more causes of abdominal pain and more pre-morbid conditions. They can have diabetes, hypertension, they can have lung disease. So in older patients, laparoscopy is better because you can diagnose, you can do an overview of the whole abdomen before operating. And it's really not so common. In pregnancy, I already mentioned it, 1 in 800 pregnancies get appendicitis. And the main challenge of diagnosis appendicitis in a pregnant woman is the location of the cecum. As the uterus keeps growing, the cecum gets pushed aside and up. So the pain might be different from a more common case of appendicitis. So that's the challenge of diagnosing it in pregnant women. In children, 250 out of 100,000 children get appendicitis. So it's really the most common age to get it, and it probably has to do with the lymphoid tissue. Stump appendicitis is 1 in every 50,000 appendectomies. Chronic appendicitis happens when there's recurrent right lower quadrant pain, but it's not associated with febrile illness. And the imaging suggests that the appendix is dilated. But usually these cases get better by themselves. Sometimes the patients do say, I ask them whether they've had that kind of pain before, and sometimes they say, yes, I've had this pain before, but it went away by itself. So that patient might have had appendicitis that had a spontaneous recovery, and they keep getting it. So there is chronic appendicitis. There's another disease. Well, it's not a different disease. There's another cause for appendicitis, and it's called periappendicitis. What happens is sometimes there is something that is there is a external disease from the abdomen. For example, you can have perforated hollow viscus, you can have a perforated gastric ulcer, and the gastric acid comes out and goes to the pelvic floor, and the appendix gets irritated by that. But it's not because the appendix was to blame. It's because something else is to blame, and that is inflaming the appendix. And the pathophysiology I explained to you, it is usually from inside out. The problem begins on the inside of the appendix, and it goes working its way out as it progresses. But periappendicitis is from the outside in, when pelvic inflammatory disease, salpingitis, diverticulitis, inflammatory bowel disease, or a perforated hollow viscus irritate the appendix, and that they usually have to be taken out as well. Incidental appendectomy is when you're operating on a patient due to a different cause. You can be operating on a patient, I don't know, but for any reason, and you decide to take out the appendix so that they will never get appendicitis. And that is not recommended anymore. There might have been a time where it was recommended, but not anymore. If the appendix is not inflamed and it has nothing wrong, there's nothing wrong with it, it's better to leave it there, because after 25 years of age, it's very unlikely to get appendicitis. So an incidental appendectomy is not recommended. Maybe, I don't know, I did not research this, but maybe astronauts or people who can't access health services quickly might have to get incidental appendectomies before going into space, just in case they need surgery when they're up there. But it's not recommended when you're on Earth the whole time. And lastly, there can also be appendiceal neoplasms. They can be tumors in the appendix. And 2% out of every appendectomy specimens have a tumor. So it's really low rate. But that is one of the things that is argued against antibiotic therapy only. You can miss an appendiceal neoplasm when you just give antibiotics. Whether if you had operated on the patient, you might have seen the tumor and taking it out. So that is another ethical question about the use of antibiotics as the sole treatment for appendicitis. And here are all of my resources. I recommended a few to you, and I think you might want to take this into account: the Jerusalem guidelines and the article describing the pathophysiology of appendicitis. So that is all.
Thank you so much, doctor. It was really helpful. It was really interesting. And also, I think it's one of the most easy way to understand what you explained. I don't know if any one of you has one question. You can write it down and you can open your microphone. And while we are waiting for someone to ask you, I do have a question. Can you explain us, or can you tell us, what is the relation there is between the diet and the appendicitis?
Well, in adults, it is thought that eating food with seeds might obstruct the abdomen. It's not really proven. Appendiculis are a piece of feces that's really dry, that's really hard, and maybe a slow bowel movements can aid to that, but it's not really proven whether it's the diet has a very important part in it. It's still a lot of there's still a lot of research about why the appendix gets inflamed. There are theories. Some of them are infection by some different pathogens than the ones showed here. E. coli and Enterococcus, they can be different germs, and they might cause appendicitis. Or even the breast milk feeding. When a baby is breastfed, they have a lot more defenses against all of the diseases, but it has also been noticed that breast milk might protect against developing appendicitis or developing gastrointestinal diseases.
Okay.
So that might have something to do.
I have another question. When you have
Yeah.
an appendicectomy, have you ever heard or have you ever seen a difference in the microbiota in the patient? They can be affecting all the physiology of the gas in the stomach or in the intestine. I don't know if there is an impact after that you have an appendicectomy. What is the impact in the microbiota and all the diet stuff?
I'm not sure about that. You know, the research about the role of the appendix is still going on. It is said that it helps to maintain a healthy intestinal flora. So it might have an effect on the way the intestine reacts to infections. But, you know, I really don't have any specific information about it just now, but it might have some repercussions. You know, it's not a vestigial organ anymore. It was said before that it had no use, but it is being studied, and more functions are being found to the appendix.
Oh, that's really, really interesting. And if anyone has one question, you can do it. And I don't know if you can tell us or you can give us some advice, for example, for the student of gerontology, what can they observe or what the risks are for the people that are getting old to the risk of having appendicitis?
Well, the difference between a young patient that has appendicitis and an older person with appendicitis is that they do not have as many, their inflammatory response is not so good. So they might not develop all of the symptoms. They might not get fever. They might not get the pain so important because their inflammatory response is not the same. So a patient with an elderly patient needs a little bit more testing, because it's a little bit like the children, you know, sometimes they just stop eating and no one knows why they stopped eating, and they might be dehydrated, they might have a urinary infection, they might have appendicitis. So in those cases, it's better to have a full workup of the patient, a chest x-ray, urinary exam, sometimes a CTAC. You know, they have to be studied a little bit more because the diagnosis is more difficult in them.
Yeah, it is. And which is the frequency of the patient, of the elderly patient with appendicitis, is high or is not that frequently to find one?
No, yes, it's not that high. The highest frequency for appendicitis, for developing appendicitis, is in the second or third decade of life. Younger than that is not very common, and older than that keeps getting more rare. But I found that there is also a study as to why sometimes the elderly patients get a perforated appendix really fast, and they do not inflame the way the young people do. So that is still being studied, but it's not so common. It's not so common. As the age progresses, the person is aging, the risk for appendicitis keeps getting lower.
Okay. No, thank you so much. It was really interesting. Thank you, doctor. Anyone has one question, you can write it down. You can open your microphone. No, I think the presentation, it was really good, doctor. I really appreciate what you did. And also I appreciate that you are a second doctor. You can give us a webinar. So I hope you can join us the next 2021, and we can learn more about your techniques and all the things you know. So thank you. I'm really happy to have you here. So welcome. And also thank you everybody for being here. And I hope you can be with us tomorrow. Tomorrow the topic is going to be pathological obesity. I hope you can join us. So thank you so much, Doctor, again. And so good night, everybody.
Thank you.
See you tomorrow. Thank you, Doctor. Bye.
Thank you. I hope it was useful. Bye.
It was. Thank you. Bye.